we are Sheena.
Right.
We're getting better.
We are getting better with that. All right, guys. So today we have a really exciting topic, hot topic in our field of interventional orthopedics and regenerative medicine. So that includes, PRP, stem cells, and a bunch of also more advanced procedures that we'll definitely go into more detail about. So I'll have Dr. Williams, can I give us an introduction of our special guest today?
Yeah, so I'm very excited to have two of my good friends on, Dr. Ugochi Azuike. We went to medical school with each other, and I remember the day we met.
Me too. I saw you from afar, and I knew we were going to be friends.
Locked in. And then my cousin, Dr. Chris Williams. Chris and I met when I think it was in Boston the first time, Chris.
Yep.
So Chris's classmate is married to my line sister's Chris's class, married to my line sister. I was trying to get it together. So we had met in Boston and dined. I got to meet his wonderful wife and the rest of your classmates. And then lo and behold, Ugochi ends up being under you in her fellowship. So I'll let you guys. Yep. So if you'll tell us a little bit about your training, Chris, and tell us where you're from, and then we'll have Ugochi do the same.
Awesome. Yeah. So I did all my medical school and residency training at Emory back in the day, finished residency in 2016, and then set on the path to get more specialized training in interventional orthopedics and regenerative medicine in Colorado at the Centennial Schultz Clinic for a year, then stayed on staff there, and then transitioned to Atlanta to open my own practice, Interventional Orthopedics of Atlanta, where kicking butt and taking names as we speak.
And before that, you served in the military. Thank you for your service.
I did. Thank you very much. Yeah, I appreciate it. I'm originally born and raised in Jacksonville, Florida. Went into the Air Force out of high school, did 4 years active duty, served in Kuwait, stationed in England for a couple years, and then decided that I guess I'll go to college and go to medical school and all that fun stuff. So
awesome.
Dr. Williams actually has a really cool story, and there's a video on that story that kind of goes into a little bit more depth about it.
I think I need to find it and then
it's a cool video that kind of tells about his story and things like that. So
no, that's amazing. We'll find it. We'll put it out there.
We'll find it. Yeah, Benecia and I we can find anything.
Yeah, I'm like, you don't have to send it to me. I'm going to find it. So.
Don't dig too much now.
Right. Dr. Azuike, please tell us more about yourself.
So, like Benecia said, we went to medical school together, Texas College of Osteopathic Medicine. Before that, I went to college at UT Austin. I'm originally from Nigeria. We moved from Nigeria to Houston. I went to a small private school there, then Austin. Then medical school, I did my PM&R residency at Baylor College of Medicine. And then that is actually where I learned about regenerative medicine and interventional orthopedics. From there, just like Dr. Williams, I did want to get a bit more specialized, and I did the Centennial Schultz Clinic Fellowship, which is a year long. And then after that, I stayed on staff for another year and a half. And then I moved to Houston to join an interventional orthopedics clinic.
Great.
Excellent. Very good.
And I must say as well, while at CSC, Dr. Williams was my mentor. And so he really kind of held my hand through a lot and helped me a lot. And I'm just he won't say it from himself, but he's one of the smartest physicians that you will meet out there. So
yeah, I think we can all attest to that. We've all taken courses from Dr. Williams.
Great
teacher, so highly impressed. Such a good teacher and patient.
Very patient. Yes.
You have to be patient with me and help me out. But to this day, when I need help, he's still there to give me help. So, Chris, thank you.
You're very welcome. Made it very easy.
Oh, all right. Well, let's go into a little bit more detail about the field of interventional orthopedics. What exactly is it? Is it an actual field you can do a residency in, or how do you get into that? And then kind of how did the field come about?
I can take a stab at it, Ugochi, then you can piggyback if that's cool.
Yes, please.
Yeah, so the fields kind of spawned out of, the merging or bridging of the gap between traditional orthopedic surgery and non-operative sports medicine, non-operative orthopedics. So, it's very similar to how interventional cardiology was born out of traditional cardiovascular surgery, and then also traditional non-operative cardiology, and really trying to find better solutions for patients that had heart attacks, right? So then you had the field of interventional cardiology going in the 80s, 1989-ish, and then what we were trying to do was a similar feat, which really started probably by a French physician in the late 80s to early 90s, who started doing intraosseous injections for avascular necrosis. And then over here in the US, in Colorado, some of the early pioneering work with treating osteoarthritis of the knee and intradiscal injections back in 2005 and 2006. And so now you hit fast forward, and now just about every, program, whether it be sports medicine, interventional pain in the United States, ACGME accredited or non-accredited programs are doing some form of interventional orthopedics, which is just really how do you treat every musculoskeletal injury from a biomechanical and pathological standpoint, whether it be needle-based or more advanced interventional procedures such as drilling in the bone, just trying to bridge that gap. If we can prevent surgery, the better, usually is a better situation.
Yeah, he pretty much hit that on the head. So just to sum it all up, I guess, interventional orthopedics, there are a lot of procedures out there in the field of orthopedics, and I don't remember the exact percentage, like 60 to 70% of elective procedures right now can be treated non-surgically. So just in a nutshell, we're trying to help prevent people from having to go through unnecessary surgeries.
Yeah, and then also I know you mentioned where can people get training. Most of these techniques, it's really, what I did my training in is kind of what most traditionalists would consider a sports and spine fellowship, kind of giving you everything from an interventional spine standpoint, all of the techniques from C0 facet joints, interlaminars to SI joints, but then also bringing in all the sports medicine ultrasound techniques for peripheral joints under one umbrella. So not only how do you inject what you want to inject, but what do you inject when you want to inject it? So the orthobiological component as well. So we kind of tie in everything. And there's a couple fellowships that have kind of added in more comprehensively. I actually started my own fellowship last year in combination with Kim Mountainer at Emory Sports Med. We had our first fellow who's finishing this year, Adam Street. But, of course, you can do Emory Sports Med has a pretty good foundation, and you're not going to get line with traditional sports med, as Benecia, Dr. Williams can probably attest to a little bit better than I can. But the Bodor Fellowship in California, pretty good one. There was one that Dr. Victor Ibrahim, rest in peace, was doing up in DC, which I'm not sure if they're still accepting fellows at this point. And there are not many fully, functional, all-inclusive interventional orthopedics fellowships out there, other than, traditional kind of sports spine or some sports med fellowships out there that you kind of have to take an interventional orthopedics or interventional orthobiologics foundation courses. There are about 400 hours worth of courses through the IOF. I'm one of the faculty members. Ugochi, Dr. Azuike is a faculty member as well. And they offer, courses on how to do all of these techniques that you can get additional post-residency, post-fellowship training in as well.
Yeah. Sheena and I were lucky enough to know Ugochi and took advantage of multiple of those courses. So highly recommend doing that.
They do offer scholarships too. So if someone's in residency and even as a PGY 2 or 3, I don't remember when the cutoff is, but I think 2 or 3, they're offering a lot of money to come and take these courses, and then you can go back to your school and kind of try to start a club or implement some of the things that that we're all learning up there and that we're teaching there.
Right. So I, advertise this as you guys truly being experts in the field. There's a lot of people that do regenerative medicine or stem cells. Tell us a little bit more about your fellowship. I got to see you go through it. I know how much research, I know how many hours I know how you guys were on the grind. Ugochi, Dr. Bhuva, and myself were all in fellowship at the same time. So we got to commonly get on the phone and talk about those experiences while you go through it. So tell us a little bit more about that.
The fellowship for me, it was great, but like, we had to do a lot of research. And coming from Baylor, you have the option to do research, whether if you want to or not, but this was a required component during this fellowship. So that part was a little bit more difficult for me because I wasn't used to doing a lot of research, but I could really, really attest to how important it is to do research in the field that you're in. Do research hands-on, read research papers, and get a deeper understanding of what it is that you're doing. There are tons of doctors out there right now claiming that they're experts in orthobiologic treatments when they actually haven't published anything in the field. And a lot of times they actually cite publications that really don't have anything to do with the type of treatment that they're even offering. And so, from what we were able to do, we're doing evidence-based medicine. And I mean, in Colorado, we have a PhD-led research team, a full-time biostatistician. I wasn't used to any of this type of stuff. And I mean, after coming in and then learning, I did some ultrasound at Baylor and actually started our ultrasound club there. But I really didn't get much spine. And I know everybody's residency is different, but I didn't get a lot of spine. So kind of jumping in, we went full throttle into all of those procedures. And then after clinic, we would do research. And we're working on multiple research papers at one time, but all relevant clinically, if that makes sense what I'm trying to say. So a lot of clinical application to the research that you're doing, which does make it better because you're able to see the correlation with what you're studying and then what you're doing right then and there. And so we recently published a paper on rotator cuff tears where we studied complete and partial tears, and we one group was treated with stem cells, other group had physical therapy. And the stem cell group ended up showing an improvement in pain and function. And we have the other half of the study coming out later. It was kind of a smaller study, but randomized controlled trial with really good results. And that's just one thing that I was working on while I was there. We had another study where we were studying the benefit of using interosseous injections to treat arthritis. We had an ACL paper going. All of my papers Chris was a part of and helped with. But I think that really made a difference in my level of understanding. And this is coming from someone that just really didn't do research at all to now being a published author. That was kind of huge for me because I just didn't have a background in it, but we do so much of it. You kind of have no other option but to become an expert in your field, the amount of studying we're doing, the amount of research we're doing, and then the amount of hands-on application.
Yeah, I think that's a great point. Congrats on that study. I was just reading it today. Yeah, and that's huge, man, because I've been through a lot of different things and I've never been more sleep deprived as I was in fellowship, right? So I think when I finished, I had 6 research papers published and 4 book chapters in 1 year, right? So you are on the ground running, 100 miles an hour, they demand a lot. But it equips you for the real world because, when you're getting out here in the real world, nobody's holding your hand. You have to know how to interpret papers, especially when there's so much pseudoscience available with the field that you're in. You have to be able to weed through that to educate patients and your colleagues and keep yourself up to date on the trends, whether it be FDA regulations or just new science coming out about what we do. So it's a lot, it was very rewarding and fun at the same time and stressful and all of that stuff put together. But yeah, got to pay the cost to be the boss, as they say.
No, it's true. And you guys do a lot of advanced, like Dr. Bhuva touched on, a lot of advanced injections, and you guys are excellent at those advanced injections. So you shouldn't just trust something like that. And they're expensive with just anybody. So definitely seek out those who are experts.
Yeah, and that kind of, brings us to our next point. So this next question is kind of two parts. So as you guys are well aware, there are a bunch of doctors out there, even some chiropractor groups that are saying that they're doing stem cell injections and yeah, exactly. Stem cell injections, PRP, all this stuff for all sorts of stuff. So what advice would you give to people who right now are physicians in practice and their, patients ask them, hey doc, what do you think about stem cells or PRP for, my knee or my back? And then additionally, for those physicians who are interested and may not have had, the background and they want to get into regenerative medicine, what advice would you have for them?
I guess I can jump on that one first. Maybe I'll answer the first part and you can answer the second part. Yeah, so how do you have that conversation? I always start a conversation as I do with patients, whether it be patients or physicians. There is no one quick fix out there. There's no free lunch and there's no magic pills, man. So this stuff is not for everybody, just like whether any intervention out there, whether it be an NSAID or a surgical intervention, does not work for everybody. No one size fits all. I think for the right candidate, you can have an open and honest conversation with patients and, kind of allow them to be as informed and make an informed decision as a consumer as possible. But from a physician standpoint, the onus is on you, because when the FDA or the regulatory body or the legal system, holds your feet to the fire, you better have some legal standing to stand on. So I always, tell people that, get into this and they're injecting PRP, transfemoral epidurals, like I wouldn't do that with a 10-foot pole, because if something happens, you have no legal precedent to stand on, right? Mm-hmm. So you always have to think about, and different states vary, but you always have to think from a legal standpoint, are you making the right decision? But also from an ethical standpoint, are you making the right decision for a patient as well? And just making sure you're not making the right decision, but making sure they're as well educated about these things as possible. I always print out research papers for my patients and give them as much information. And I talk about everything: conservative approaches, surgery, percent and outcomes with those things as well. So that way they can decide, hey, it may not be the best thing for me. I may have a 70% chance of having a good outcome, but with all the knowledge that I've been made aware of, I'm still going to do it. And I think it's the right decision for me. So.
What was the second part of the question?
Just if physicians in practice are interested in adding regenerative medicine into their own practice, what advice would you give them? Are there any things that they should any contacts that they can make, or are there any courses or anything out there that they can do?
Okay, well, kind of like Dr. Williams talked about earlier, the Interventional Orthopedics Foundation gives courses year round. So you can always join the foundation or sign up to take a course. Now, I'm not sure how it works because it's kind of spread out now, but I know, like Dr. Williams, at your facility, you had started offering interventional orthopedic courses. And I think there was one in Florida and one in Seattle. We're looking into possibly doing one on this side, but I think, honestly, I haven't really joined a foundation outside of the Interventional Orthopedic Foundation that's doing the level of courses the way that we are. And I'm not just trying to say that to just plug us, but really the standard has been set there. So I would reach out.
I think that's a good point. So the IOF is great. Toby, the Orthobiologic Institute, they just had, so their course is usually second week in June. It actually was from Friday and Saturday. I lectured for that as well. But, that's a great course. It's probably the longest running orthobiologic course out there. And then the AAOM, which is more of an older school kind of prolotherapy approach, but they definitely are some of the leaders and contain a lot of, have a lot of the veterans in the field that are members of the AAOM that can give you a large percentage of knowledge and a good foundation. But just AAPM&R, is more cookie cutter stuff, to be honest with you. But AAPM&R usually does have a section on regenerative medicine and orthobiologics. So I'll say start off with the conferences, get to know some of the leaders in the field, reach out to them, and then it's a big pill to swallow, but start small. Say, hey, I just want to learn about PRP first, and then go to adipose tissue or birth tissue products or BMAC, kind of bite each piece of the cookie off smaller portions at a time so you can start learning a little bit more.
like levels, right? There's levels to it. And Dr. Williams, you had emailed me previously. I know you're going to be doing some consulting, and it's going to be launching very soon, so physicians can reach out. You want to tell us a little bit more about that?
Yeah, so yeah, just from, the basic question that you guys asked, we have so many novices out there that, these folks have been doing, pain medicine or sports medicine for 20 years, and they're trying to look for a shift change. And it's like people get lost. They're like, well, where do I go? So I did form a consulting business. I have an LLC for it. The website is launching by the end of this month. So it's supposed to launch like a month ago, but everybody is well aware of COVID-19 loveliness that it has brought upon us. But interventional orthobiologics consulting will be great because we have docs from California to New York that are involved that can actually allow you to reach out to them and do one-on-one consulting, whether that be chat, text, FaceTime, or Skype or Zoom, or even hands-on. You can come to their practice or they can come to you. So it's kind of a la carte depending on how much you want them to be involved, just to make sure that you're doing this in a safe manner and provide educational resources for you as well.
Yeah, because I think a lot of us who are fellowship trained, we know how to do, I wouldn't say as advanced as you guys, but we know how to do like the bread and butter injections, correct? But I think just using it on appropriately, like I'm lucky enough where I have a question, I call Ugochi, she's like, you're gonna take a little D5, you're gonna mix it, put a nanogram of this, that. I'm like, wait, whoop, scale it back, and we write this down. So I think that's excellent that you guys are doing it. I think that regenerative medicine is definitely the future of medicine, and it's being more widely accepted. There's a lot of older school physicians, they're like, oh, well, that stuff is, it's a pseudoscience, or there's no research behind it. But as the research is getting better and better and more streamlined, you see that is not the case. And then same thing with some of the traditional treatments that we're doing, some steroids and NSAIDs, we're realizing like, hey, this is not great for cartilage. This is just what we were used to using for so long. So I think we're seeing a shift in medicine right now, and I'm glad you guys are at the forefront of it, and I'm excited to learn from you.
Yeah,
I think if more physicians just knew applications, like how to, like where to apply what, they would definitely start using it a lot more. And that's pretty much the type of questions that I get from you guys, or people will come in with a case and, oh, I've got someone with joint instability and I've heard Prolo is this, and where would I do it? How would I do it? Even just simple, basic things like that, to teaching someone how to inject ligamentous teres. Dr. Williams taught me how to do that. And so, the scale is broad, but there's room for everybody to learn a little bit of this. Because I think right now, maybe 4 to 5% of physicians are using even diagnostic ultrasound. So, some of the older generation, they're kind of like, I do it this way, and this is the way I'm gonna stick to it. But there are a lot of people out there just willing to learn, and even just learning the basics of ultrasound diagnostically, and they could even just apply it using regular intra-articular injections, things like that. That would be a good start for people.
I remember, go ahead, I'm sorry, please.
No, I was just going to say, I do have a textbook coming out on interventional orthopedics. I guess I should plug that. Here is the publisher. It'll be out some point in 2021. We have every big name of who's who in the field, from, Malenga, Mautner, everybody. It's over probably about 50 contributing authors, and it'll have every technique that we learned and how to do it in ultrasound and fluoroscopy technique version. So that'll be coming soon to the theater near you.
Now, that's awesome. Huge. That's actually a really, really big deal, because there isn't a book like this out there. Because, there's either, where you're doing maybe just traditional pain type of injections, and then there's books that are just more so leaning towards diagnostic ultrasound. But he's combining both of those, and then even combining a lot of these advanced and not so advanced too, but the things that just aren't the norm. I didn't go anywhere and learn how to treat an ACL, or a PCL, or, even just MCL, little things like that. I mean, he's going through all of those things. Anybody that is a proceduralist, this is a book that they should get. I mean,
can we pre-order this book from you? Is that out yet?
We're all ready.
Yeah, I know, right? They're already, everybody's ready.
Listen, sold.
They're coming out with the pre-orders for IOF 2021. So February 2021, they're looking at actually doing IOF in Phoenix and not virtually. And so they'll have the publisher will be there with all the pre-orders and all of that fun stuff. But yeah, so it's coming really
We'll
quickly.
be sure to we'll post that.
Yeah, I think programs need to get this book, like different.
No, I think it's great. Yeah. So we have a lot of our following is a lot of medical students and residents. So, and a lot of people are interested in fellowship. Tell them about how many fellows they typically take. And Chris, please tell us more about your fellowship, where they can apply. Same thing about the Centennial Schultz, where they can apply, and yeah, give them that information.
Cool. Yeah, so I just did a talk last week with the Emory residents about post residency job opportunities and the benefits to pros and cons to doing ACGME versus non-ACGME fellowships. I think that's always a point that you have to think about and not take lightly, because depending on your ultimate goal, if you want to do academics, then you probably want to steer clear of a non-ACGME fellowship. I am faculty member at Emory, and I did a non-ACGME fellowship, but it's not the norm, right? So, I think knowing what the end goal is, then you kind of have to retrofit what you want to do in the path to get there. But, fellowships are usually going to be 1 year. As you guys know, there's not a lot of multiple year fellowships in PM&R. But, the interventional ortho, it's similar to sports or sports and spine. It's all going to be kind of 1 year. It's a lot to learn in 1 year, and it's very difficult to have a good foundation if you didn't do a residency training program that allows you to have a lot of hands-on exposure with ultrasound and especially interventional spine procedures. Coming from Emory, I graduated with 400 or 500 interventional spine cases by the time I did fellowship, so I felt comfortable with moving the needle. And then it was able to transition a little bit easier. So I think having a good foundation and knowing your weaknesses before you apply to fellowship is key. But the Centennial Schultz Fellowship is pretty difficult. It's only between 2 to 3 spots a year. And because of the coronavirus, they're only doing 1 fellowship spot this coming year.
Oh, wow.
Because it's not cheap. Most, as you guys know, most places are on hiring freezes. Most of the fellows that graduated are struggling to find jobs. So they're taking 1 fellow this year. And I think that's probably going to be the going standard. I'm actually not even doing a fellow this year with my combined fellowship with Emory, extending the fellowship of my current fellow because he's active duty Army for about 2 months to give him some additional training, because we haven't had a fellow for the past 3.5 months since all of this popped off.
Right.
The patient and protect him as well. So, but there's a lot of good options. I'm more than happy. I'm always transparent about the pros and cons of these things. Anybody ever want to reach out to me, I can definitely chat.
Very good. We did a talk like that a few weeks ago. We had Sheena's non-ACGME sports and spine. I'm ACGME sports, and then we had a PM&R ACGME pain fellowship trained, and then anesthesia fellowship trained. So they kind of went over the pros and cons of each of that. And then I think you gave exact advice that we said, like, kind of know what you want to do at the end game, and then you can retrofit kind of where you want your fellowship to be. That is very huge to decide probably by your PGY, and then by the middle of your PGY 3 year, I would say you kind of have to know.
Yeah. Earlier the better. Yep.
Yeah, for sure.
And Benecia talked about it a little bit. So most of our audience is late medical students and residents. So if you can just kind of go back to the basics of exactly what is PRP and stem cells, and kind of what are some of the procedures that you do.
I'll let Dr. Azuike take that. How much time we got?
Yeah, I was gonna say,
in 2 minutes.
I can give you just a very, very condensed explanation, but PRP stands for platelet-rich plasma. And so that comes from a regular blood drop that you would get just from a vein. You take that blood, it's spun down and separated out to get the platelets. And then those platelets are then concentrated to the level that you need. With Regenix, we have a proprietary lab platform where we're able to concentrate our platelets a lot higher than the baseline, because we're doing this by hand. But I think a lot of average bedside centrifuges are concentrating platelets 5 to 7. Are there any 10x centrifuges, Chris, that you know of? I thought that was coming out.
There's one Arthrex Angel system. It can technically go up to 18x, but it doesn't go up to 18x. But it can concentrate pretty high, standardly probably up to about 12x. So
okay.
And good PRP is yellow. I learned that because Ugochi would be seeing pictures and she'd be like, that's pretty red to be PRP.
A lot of my friends will send me pictures like, oh, my clinic is starting to do PRP. And they'd literally send me a picture of some really red PRP. But then that we can go into like a much deeper conversation going in, you know, talking about leukocyte rich versus poor and whatnot. But PRP is an amber golden color. And so the reason we were even talking about different concentrations is, you know, everybody's different. And when you're looking at a patient, depending on whatever their issue is, it's not a one size fits all. So some patients may do better with a lower concentration and some may do better higher. And that it can make a difference. And so that's just kind of a quick little summary of PRP. Stem cells, I don't think they call them mesenchymal stem cells anymore. What am I trying to say? Medicinal signaling cells is what we're calling them now. But we, in my practice, get them from bone marrow or from fat. And when we're getting them from the bone marrow, we're getting them from the posterior iliac crest. And then when I get them from fat, I'm getting them from the gluteal region. When I rotated with Dr. Montner, they were doing the lower abdomen. I don't know if you're doing any other areas, but you can get it from different places. But that's kind of just a brief little summary about what they are. And then in terms of clinical uses, I think that's what you asked.
That's like, what kind of procedures do you guys do?
So what type of procedures?
Yeah, what's like your bread and butter, would you say, procedure?
So in my office, bread and butter, probably knees, shoulders, and spine. But in terms of what we can do, pretty much any orthopedic condition from head to toe is what we're treating. So that's going to include, you know, I had a patient come in. I'm also a DO, I do osteopathic manipulation. And so I had a patient come in that I was doing some craniosacral work on. And I manipulated her, but it wouldn't last, transient improvements. Once I actually started, I did a platelet lysate prolotherapy procedure where I injected the ligaments in her cervical spine and the posterior sacral ligaments as well to help increase stability. Her headaches went away, and the pain in her neck and shoulders that she was having went away. And that's just something simple, just ligament work there. But head to toe, I mean, we're doing cervical facets, we're doing, this was a really good one. I have a boxer that came in and he had a cubital tunnel, and we're doing hydrodissection of nerves. And so people that come in with numbness, tingling, shooting pains down their elbows or hands, we're actually putting platelets around the nerve to help heal and repair the nerve. And I just mentioned that because it's not just muscle and bones. We are treating ligaments, we are treating tendons, and just in general, what I just really, really love about what we do with interventional orthopedics is finding the root cause of the problem. A lot of times people don't really pay attention to biomechanics and how biomechanics can play a huge role in your pathology. And so I'll use the example of my aunt that came in with plantar fasciitis. I kept telling her, I think, you know, we need to look at S1. We need to go back to the root. I can almost guarantee you, we've treated it. We've done, you know, everything conservatively that we could do, but it's going to keep coming back unless you treat the root. So after doing platelet lysate epidurals to S1 and then kind of treating that plantar fasciitis, I mean, the improvement remained. And so again, head to toe, if I can reach it and see it, because that's really important, everything that we do is image guidance. If I could reach it and see it, I can inject it.
Awesome.
Very good. So you guys are both in private practice. Sheena, I stole your question. I apologize. I'm just gonna jump in. What you guys can kind of tell us who do you want referring to you? What are the types of patients you want referred to you? How do people find you guys?
Yeah, so I don't like to stop anybody from coming in. It's always a good educational experience for them. But I get a lot of my patients from Emory Sports Med, Dr. Mountain. He sends me all his spine stuff because he hates spine. I get a lot of my patients from concierge PTs, physical therapists in the Atlanta area that I've kind of networked with, chiropractors as well, word of mouth, and then also from, of course, digital media, digital marketing, Google AdWords, pay for play or pay to click kind of AdWords search as well. And then just from the national platform with the company that I work with, Regenerative as well, they have a huge web presence. So patients usually go on their platform and do a search of who's in their region. But about 40% of my patients come from outside of the Atlanta area. So
they're really seeking you out. Yeah.
Patients really try to find me.
That's good.
Actually, we'll be making an appointment at some point with you so I can get this cervical intradiscal for my neck. Williams has treated me several times, for which I'm very grateful.
And we've had friends go down and Ugochi's treated. We're like, I need to make an appointment with Ugochi. Go down, yeah.
So I definitely will do that. But just kind of to add to what he said, I treated someone that came in for low back and knee issues recently. And, what they told me was when they felt that they had knee pain, what's the first thought that you would think, the patients have? They go to their primary care. Sometimes they may seek out, a sports medicine. But he said he went from his primary care physician who, PCPs, they do everything, so they're going to refer you out. They were referred out to then a family practice sports medicine physician who, kind of I was surprised, didn't even prescribe physical therapy or anything, but then they referred him then to an ortho. And obviously orthos are orthopedic surgeons, they're surgeons, so they want to cut. And so he just kind of hopped around and he didn't feel like he actually was going to someone that was going to give him a non-surgical solution to his problem. And he was like, I wish I would have met you sooner and I didn't have to play this game. So I'm not really sure yet how to kind of let people know, because a lot of people don't know what PM&R is either, because he said he would have at least even started at PM&R. And so I try to go out to different groups and give talks. I give talks at a lot of physical therapy groups and chiropractic groups so that they can refer over as well. And then just, I'm still trying to figure out how to get the word out about us being musculoskeletal and spine physicians. You know what I mean? Just because there's a lot of passing the baton. When if we could get them directly to us, save a lot of money and time, because I end up seeing people when it is I'm now the last option. They've gone through everyone. They've had multiple steroid injections. They've had multiple surgeries and they're not getting better. And so they looked for everything that they can find. And then finally they come to me.
Yeah, I think that's the unfortunate thing, because I think that we are usually the last stop, and it makes our job very difficult. And then the patient's expectations are also. So that is a very huge issue. So I don't know.
I think that's kind of in general for PM&R too, right? Because we're usually like they're like, oh, send it to the PM&R doctor. So I can imagine like you guys even being, on top of that.
And how to fix it, I'm not really sure, outside of just trying to make my presence known, giving talks to let people know.
Education, right?
Education, and talk to as many people as you can to spread the word.
Yeah. I think that with social media, and sorry, my dog, of course, he likes to be part of the live talks. I think with social media, you really have to try to optimize that and form that presence there, because there's so many people that are on social media. And you can do these live talks, and then save it, because we will save this. We'll put it on our IGTV so people can consistently watch it. We'll put it on our YouTube page, which you can then access as a podcast too. So, just using those different various. So yeah, I highly suggest you maybe just start with one topic, say, hey, I'm going to talk about PRP and educate on it, and then let it disseminate.
And
Yep.
before COVID, I was doing a lot of seminars with patients. I
Mm-hmm.
bring about 30 patients out. I do a lot of education for the residents and things like that. Doing webinars, I think I have one scheduled maybe in 2 months from now. I think it's great. It just allows you to have another platform, patients to reach out and touch you digitally, and it's free. So everybody likes free education.
Free.
So
Yeah.
Stephen Oliveira is your biggest fan, Dr. Williams.
Yeah.
He's like, you are
He's been
he's
leaving
on
a lot
the
of comments.
he's on the Facebook Live. He's like, he's amazing. I promote you. I tell everyone I go to you to go to see you. So
awesome.
yes, one of your patients. And that tells you, yeah, that's awesome. Pulmonar in Mexico. Awesome. We appreciate you.
Oh, we did his ACL together.
Martinez. Yeah, he put that earlier.
That's what I was saying. Yeah.
You remember Dr. Williams?
That's excellent, man. That's cool.
Yeah.
All right. So speaking about these procedures, the one thing right now is a lot of insurances don't cover them. I think that's changing. I think I've been hearing maybe some workers' comp insurances are starting to cover some stuff like PRP. So, can you talk a little bit about the cost? Obviously, on your end, it takes a lot of preparation, getting the sample PRP and then the stem cells. So obviously that will go into the cost of the procedure, but go into a little bit of detail about how much these procedures cost and why they cost what they do.
And then we'll open it up to questions to the audience. So if you have questions, the audience, please ask. We'll get to that after to answer this question.
Dr. Williams owns his own clinic, so I'm going to let him kind of talk about that, because I know we've talked before about having to adjust pricing and, insurance versus not taking insurance. I think you gave me a better understanding of that. So.
Yeah, so I have an old school philosophy, from, street pharmaceuticals and dealing drug type, mentality of everybody eats, right? So, everything always has to be fair. And I feel like, there's a space to make money and to make sure you can support your staff and your family, but also not rip people off. And so I think once you have an ethical mindset and doing what's fair, I think that's the foundation. So my prices personally for my practice for what I do is probably, on par with other physicians that do what I do, is probably 50% cheaper. And I still do well. And what's well, we can classify that, but I'm doing okay. I don't know if I should say that, but I'm doing good. Bills are good and people are taken care of, man. I try to be ethical and make sure, things are good. But PRP, it's a spectrum. PRP for adequate PRP, not just into a joint per se, but if you're talking about treating an entire structural component, so treating all the ligaments of the knee, you're probably looking at somewhere around $800 to $1,200 for one complete PRP treatment. For spine, we're talking about probably around $1,500 to $2,200. How many structures in the spine are treated with PRP, and then bone marrow concentrate is probably a fair range of pricing, is usually around $3,000 to $5,500, depending on how many things are being treated. When you get to probably $7,000, $8,000, $9,000, $10,000, it's a little bit on the expensive side of things as well. But I think, adipose is probably in the same price realm of bone marrow. Usually, also the birth tissue stuff, you really shouldn't be paying over about $1,500 for amniotic, umbilical, placental type of tissues, because you get them from the manufacturer about anywhere from $400 to $800. So having a ridiculous markup on that when you don't have to do any preparation is not ethical to me. You only have to mix it with saline and shake it up and then throw it out and, you just inject it. So that's kind of the price range.
And I feel like that's totally reasonable considering that a lot of patients have a really high deductible plans and have to pay that anyway. So
for surgery, yeah, absolutely. That's a good point. Most of the day and age of high deductible plans is here. Probably all of us have high deductible plans. You're going to pay something out of pocket. So, we do take HSA accounts as well. Care credit is something that I take in my practice where my practice actually pays the premium or APR for the patient to have an interest-free window, kind of same as cash, to get the procedure done, like 6 to 12 months. And also Regenerative is a company that's working with self-insured employers as well. So, your big players, your PepsiCo, Home Depot, they have about over 6 million employees and their family members that get our procedures at no cost. So, you know, that's been huge. I think it's a great option for them. Not to say it's for everybody, but at least it gives them the option, right? So to say that, hey, I got severe knee OA. Do I want to go and have a knee replacement at 45 years old, or do I want to try bone marrow concentrate? Neither of which is going to last me forever. But hey, if I can get 6 or 7 more years out of my knee before I have to have it amputated, then let me try that. Or if I'm not a candidate for bone marrow concentrate, at least I know that, and then I could go and have a knee replacement. But at least you have both options and you don't have to pay anything. So we're trying.
Excellent. Okay, we have some questions.
Yeah, he's given some good questions here. So he asked, so Donald, have you to notice certain injectates like PRP, adipose, etc., working best for certain indications like knee OA and lateral epicondylosis, or is it very individualized for each patient?
I'm getting lateral epicondylitis. I can either come down.
Uh-oh.
Visualize
Go ahead, Dr. Azuike.
Sorry about that. You know, we treat every case as its own unique case. That's not to say that, you know, we haven't done the research and seen studies and patterns, but there are tons of research right now that show the benefits of PRP for things that like lateral epicondylitis. And so those are the type of things that we would try first. And then with that, again, looking at the full picture, do they have a large tear of that common extensor tendon there? If it was a very large tear, that's when I would move into something like the bone marrow concentrate. So everybody's different. It really just depends on what the issue is. A lot of patients come in after maybe researching and they've seen Regenetics. Oh, they come in, they have a spine issue. I want stem cells. You know, but stem cells is not ever my go-to, like my number one go-to for spine. I never start with stem cells for spine. I start more conservatively and use platelets. And then after maybe not getting the amount of improvement that we want, we then move on to a stem cell injection.
Yeah, that's a good point. I think that, you know, to date, there's over 70 randomized clinical trials that have randomized PRP in comparison to everything from cortisone to saline. There's level 1 data to suggest that PRP outperforms cortisone as well as hyaluronic acid for knee arthritis.
Yeah,
also for lateral epicondylosis as well. So, you know, PRP is definitely more well researched than any other orthobiologic. TRICARE, which is the military insurance for their dependents and also veterans and active duty military folks as well, they are now covering PRP for knee OA and lateral epicondylosis because of the research is just there, right? So, you know, there's always this double standard, because I think the biggest thing that you'll hear when you talk to patients or talk to other docs is that, oh, there's no research for that stuff. It's just voodoo or blah, 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 blah. But there aren't 70 randomized trials for any surgical procedure to date, right? So, you know, even when we look at meniscectomy, you know, there's no level 1 evidence or level 3 evidence to say that it works better than physical therapy, right?
Right. And they do it all the time, right?
All day. Yeah. Over 500,000 of those occur every year. So, yeah.
And you'll see those people in the future for a knee replacement, or hopefully some kind of orthobiologic, because they're
every week going to get tore up.
Right.
Double stand real.
Dr. Salvador Martinez is asking, I'm going to pronounce this incorrectly, the perineural injection therapy, is it Liftoff? Yeah. Yes. I've read some more. I haven't ever done it, but I've read a lot about it.
Mm-hmm.
Yeah, perineural injection techniques, Liftoff therapy, or just simply perineural hydrodissection. You know, it's a lot of different ways you can classify it, but it works. You know, I think the most studied outcomes is for median neuropathy. And there's been at least 5 randomized trials to date comparing it to either splint or cortisone or saline. Prolotherapy or neuroprolotherapy with 5% dextrose has been randomized or compared to PRP as well. And right now, PRP outperforms all of the techniques, and then 5% dextrose, and then cortisone, and then a hand splint. So there's a lot of data out there on those techniques. And there's one good systematic review or meta-analysis that came out 2020 looking at those randomized trials.
Awesome. I love how you guys be pulling this research out. Like actually according to, when everyone says what the literature says, I'm like, they know what they're talking about.
Absolutely. Make people listen a little bit more.
Yeah.
Exactly. Like, oh, they're for real. Okay. So yeah, I guess if there's no more questions in the audience, we'll get ready to wrap it up, guys. We asked all of our guests, if you were not a rehab doctor, what would you be? Dr. Azuike.
Can I answer for her? And she can
I know
answer
it too. Let's do it. Yes. Okay. You, Dr. Williams, you answer for Dr. Azuike. We all probably know what the answer is, but what would Dr. Azuike be, Dr. Williams?
He's singing her butt off.
She'll be a singer.
Star,
Yeah.
yes.
She'll be she's going to be, yes. She is a star. Yes, exactly. She would spend
absolutely
more time doing that. Yes. And what would Dr. Williams be?
Dr. Williams be? I believe that Dr. Williams would be a professor of some sort, where he travels the world, teaching huge topics to his audience, but something that's really unique, I think, in terms of like topics. Dr. Williams, when we would be in clinic at lunchtime, we would have 5-minute HIIT sessions.
I was about to say he would be a personal trainer.
He would actually be a professor, but he would be a trainer as well, and a nutritionist. Because all of that information, and this man is like super fit too.
Yes,
his wife are
super. Him and his wife is super fit. I saw Layla. I was like, didn't you just have a baby, Layla? I'm like, where did this baby come from?
Pregnant again, and we just ran 1.5 miles yesterday.
Wait, what?
Not much.
Congratulations! More
I guess.
little Williamses.
Thank you. Yeah, about that. Yeah, thank you. Yeah, I think I probably would be a chef. I've done just about every job out there. Man, y'all make me sound so boring. He'll be a professor.
But the professor that like does fitness and stuff and goes
just knows things.
Nutrition.
Yeah, no, that's fun, man.
No,
Yeah.
that'd be awesome.
Great.
Very good. Well, we
Thank you
really
guys so
appreciate
much.
you guys taking the time out of your schedule and coming on our show. I think this was super helpful. Maybe we'll have you guys on in the future. We can do more advanced talk. I think which would be really cool and kind of have a target audience for those who are like in practice. I think.
Yeah. I think
pull in a big audience for that.
Like maybe just like back pain or something like that. Yeah.
Yeah, I think that would be very, very cool.
I could get with Dr. Williams beforehand too to help put something together.
Yeah.
Dr. Williams, I think I tell you all the time, but you're still such a great mentor to me. You helped me so much throughout my whole fellowship, and you still continue to help me today. He's always there to answer my questions. He never, sometimes you don't want to ask people stupid questions. Like I should know this already. Always patient. I just want to say thank you. I'll always be grateful.
Oh yeah.
Very welcome.
How much?
It's a big deal. You both are a big deal. I remember at the conference, I was like, go cousin, go. And I'm the embarrassing one, right?
You and Dr. Pitts took a lot of time for me. So I just want to say thank you.
Thank you. I appreciate it, man. It's my pleasure.
Okay. You guys are great.
Yeah, you guys were great. Thank you so much. And next week, we're back to our double headers. We have Dr. Brad and Susan Sarofsky. They're the fellowship directors at Desert Spine and Sports Physicians. So they're going to be talking about, what they look for in a candidate in the interventional sports and spine fellowships. And they have their private practice too. So we'll go into a little bit of detail about that as well. And then on Sunday, we have Dr. Kristen Taylor. She's going to be talking about pediatric rehab, and she's a big supporter of CBD and medical marijuana in patients, with kids, with spasticity and things like that. So it will be a good weekend. So you guys take care. Thanks for joining.
Awesome.
All right, guys,
Thanks for
take
joining,
care.
guys.
Be safe. Thanks.
Back again.
All right.